Assalamu alaikum, everyone. My name is Layan. I'm a fifth year medical student. And inshallah, today we'll be covering the Heme Pharmacology crash course. So I know this is everyone's least favorite subject, but inshallah, today we'll make it nice and easy. Okay, so the topics we're gonna go through are in this order. Now, the reason I put this order is I think this is from most challenging to least challenging for students. So I'm gonna go in that order. Also, the first 2 points here are the most time consuming, okay, from this crash course, and then inshallah it will be really quick from there. Now, first topic is antiretrovirals. Why are they called antiretrovirals? Just 1 second. Okay, so because they target the retroviruses, okay, like HIV, it's a retrovirus. What's a retrovirus? It's basically a virus that uses reverse transcriptase, okay? Like you know how in normal human biology, it's basically we go from DNA to RNA to proteins. The HIV is the opposite. It's the opposite. It starts with RNA, goes to DNA, and then or transcribe becomes transcribed into DNA and then forms the viral products. So it uses reverse transcriptase. Okay, so these drugs target these viruses, mainly HIV. Now, in order to make this concept really easy and make the drugs stick really well, we're going to go step by step in the process of how an HIV virus infects a CD4 T helper cells, okay? Because these are the cells that the HIV targets. Now, I like this order. I don't know why in the lectures it's not in this order. This is the order of how the HIV targets the cell. So we're going to move in this way, okay? So first step is the fusion or entry and fusion. Now, what happens is here we have up here is the HIV virus, and attached to the HIV are these two like legs or screws, okay? This is called the glycoprotein 41. Attached to the glycoprotein 41 is the glycoprotein 120, which are like the shoes almost, or the feet, okay? So glycoprotein 120 and 41 are attached to the surface of HIV. On the CD4 T helper cell, which is the one on the bottom here, we have two receptors. The red one here is the CD4 receptor, and the blue one here is the chemokine receptor, or CCR5, the one here, this blue one. Okay, so you need to remember that all the receptors that start with C are the ones on the CD4 T helper cell. So CCR5 and CD4 receptor. And there is a variant of this blue receptor, which is the CXCR4. Okay, so some HIV viruses, when they target the CD4 T helper cells, they enter either using the CCR5 or the CXCR4. They work very similarly, but they're different receptors. Okay, so anything that starts with C is on the surface of the CD4 cell, and the glycoproteins are on the surface of the HIV. So what happens first? First step is the glycoprotein 120 of the HIV is going to bind to the CD4 receptor. Okay, what happens is, if you can see here, the CD4 receptor, the red one, is going to pull the glycoprotein 120 down to make it close to the CCR5. Because you see how there's a gap here? The glycoprotein 120 is far away from the blue. Okay, so the function of the CD4 receptor is to pull the glycoprotein 120 down so that it can bind to the CCR5. Okay, right here. So after it does that, it will allow the glycoprotein 41 to enter the host cell. That's why CCR5 is called an entry receptor. Okay, so because after it binds to the CCR5, these two like needles or screws or whatever you want to call them, it's able to now enter the host cell. Okay. Now here, if you can see these glycoprotein 41, they're almost like screwing into like a screwdriver, or a needle. They're going into the host cell, okay, piercing into it in order to fuse the two cells together. So the glycoprotein 41 is called a fusion protein because this is the one that leads to the fusion of the both. And the CCR5 is the entry receptor because it allows for the entry of the glycoprotein 41. Okay, so this is basically all you need to know to make this easy. Now, the two things that you need to know, or the two things where we have medications to target, are the glycoprotein 41 on the HIV and the CCR5 on the CD4 cell. Okay? Now, like we said, some HIV viruses, when they come to infect the CD4 cell, they can either use CCR5 to enter the host cell or they use CXCR4 to enter the host cell. That's why we need to do tropism testing, okay? Because let's say the HIV virus, this specific strain in this person uses CXCR4 to enter the host cell. That means giving the drug that works on CCR5 will be useless, right? That's why we need to know. So, what are the two drugs you need to know? The GP41 inhibitor or the fusion inhibitor is called enfuvirtide. It's easy to remember because it has few with fusion and 40. So they all start with an F. So fusion, 40. Okay. The second drug you need to know is the CCR5 inhibitor or the entry inhibitor, which is called maraviroc. Now, a way to remember it is ROC is similar to if you pronounce this backwards, RCC, ROC, okay? So maraviroc for CCR5 and enfuvirtide for GP41, okay? To remember it as a whole, remember tides and rocks for entry and fusion, okay? Now, let's do it like a quick practice question. Now, guys, for the questions, because this is a pre-recorded session, uh, I'm not going to read the question out loud. I'm going to go through the answer really quickly. So as soon as you see a question, just pause the screen, okay? So you have time for yourself to think. Okay. So here they're asking for on which part of the cycle do we do tropism testing for what part of the cycle, okay? It's like we said, it's for the entry, right? So which is the first one? These are all the later phases, okay? So the answer here is A, very easy. This is how questions can come. Now, same concept, okay? Again, why do we do tropism? For the entry receptors, okay, to see whether the HIV strain uses CCR5 or CXCR4 to enter the host cell. So entry for tropism, okay? And like we said, CCR5, rock, okay? It's not enfuvirtide. Enfuvirtide is FU for fusion, which is glycoprotein 41, okay? We don't need this for tropism. Tropism tests the entry, okay? So enter tropism. I think it's easy to memorize, inshallah. Okay, just straightforward recall questions. Okay. Same thing here. These are all just variants of how this question can come for you guys. So they're telling you here that the HIV is tropic for CXCR4. So which drug would be useless or ineffective? The maraviroc. Why? Because this one targets CCR5. Okay, now let's say this virus, okay, it was able to enter and fuse with the host cell. So we weren't able to stop it at that point. So let's target the next step of the infection process, which is the reverse transcription. Okay, this is where the second group of medications come into place. Now, reverse transcriptase, we can inhibit it in two ways. Okay, right, it's either a nucleotide nucleoside or nucleotide inhibitors or non-nucleoside inhibitors. So we'll be going into the difference between them. Now, the NRTIs, this is the only class of drugs in the antiretrovirals that do not have a mnemonic, or I don't have a mnemonic for you guys on them, but I do have a mnemonic for every other class of drugs in the retrovirals. So because you have mnemonics for all the other groups, it will be easy to know which one is under this. You get what I mean? So inshallah, by the end of it, they will be very easy to recognize. Now, let's start with how reverse transcriptase works very briefly. Now, reverse transcriptase, like we said, it's gonna work on transcription, but in reverse. So you'll start with an RNA strand and you'll end with a double-stranded DNA, okay? Which is the opposite of how normal things work. Now, what happens is the NRTI, or the nucleoside reverse transcriptase inhibitor, it's going to compete with the nucleotides for a spot on the primer. Okay. After it gets that spot on the primer, it's going to terminate the synthesis of the double-stranded DNA, so it's not going to form it. Okay. That's how it works. Now, important things to know is that it's a competitive inhibitor of reverse transcriptase. In pharmacology, what do we mean by competitive inhibitor? You need to know this because it might come in MCQs, so you're not confused between options. When we say something is a competitive inhibitor, it means that it's going to resemble the structure of a molecule that we naturally find in the body. Okay, so here there are nucleotides or nucleosides analogs, okay? So they're competing with the normal ones in our body, the ones naturally found in our body, the nucleotides, okay? Because they're competing with the ones in our body, they're called competitive inhibitors, okay? Now, how does it stop or inhibit the formation of the DNA? It's because the NRTI is formulated in a way that it lacks a 3-hydroxyl group. And as you know, without a 3-hydroxyl group, this is a quick flashback to know, you cannot form a phosphodiesterase bond for the DNA. So it's going to lead to a termination of the strand. Okay, now, fourth point you need to remember is these NRTIs need phosphorylation to be active. What do we mean by that? Remember how we said they can either be nucleosides or nucleotides? Well, the nucleoside is basically the just without the phosphate group, right? And the nucleotide is with the phosphate group. In our body, which ones are the ones recruited in the primers and the strands? Nucleotides, right? Nucleotides are the ones that assemble to make the DNA. So the nucleoside has to be phosphorylated to become the nucleotide, okay, and then work in the body, okay? So it needs phosphorylation to be active. However, there is one NRTI that's already a nucleotide, which is the one that starts with a T. So it's very easy to remember that tenofovir is the one that's the nucleotide. They're all the others are nucleoside analogs, okay, or derivatives. So what is the high yield content for NRTIs in exams? It's the mechanism of action, so all of these facts here, and these side effects, okay? So very easy to remember them. Abacavir, need to remember HLAB570, okay? So AB is here, AB here. What does this mean? In patients that are positive for this gene, okay, they're very likely to develop a hypersensitivity reaction when they're given this drug. Okay, so you need to keep that in mind. Tenofovir, what you need to know, it's the one that's a nucleotide. And then for this one, zidovudine, it leads to myelosuppression and macrocytic anemia. The way I remember this, very stupid mnemonic. Milo likes to go to the zoo, but he's too macro. He's too fat. He can't fit. Okay, so Milo, zoo, as in zidovudine, and then macro. Okay, Milo wants to go to the zoo, but he's too macro. So whatever works, works. I'm just giving you a glimpse of how I study pharma. I hope it's helpful. Now, this is all you need to know, okay? So let's apply it to questions really quickly. Again, feel free to pause, okay? Now, here they're telling you the patient is on antiretroviral therapy. After a few weeks, he noticed low RBCs and white blood cell counts. This is myelosuppression, right? Like we said, Milo likes to go to the zoo. So this is the one that's causing it. Next, pause. Okay, same thing here. After being on antiretroviral drug, he presented with pallor, fatigue, okay, MCV over 100, okay, macrocytes. So here we're seeing macrocytosis, right? So Milo likes to go to the zoo, but he's too macro. So remember, this is for the zidovudine. So zidovudine leads to myelosuppression and macrocytosis. This is very easy. So they're telling a patient developed a severe allergic reaction and he was positive for this gene. So what drug was he most likely taking? Abacavir, AB for HLAB, okay? Same thing, okay? It's just a different way this question can be asked. Okay, so this one is a question I added, okay? So basically, it's a bit more tricky, but they might ask you in this way, which of the following is not a characteristic of NRTIs? Now, when you see questions like this on the exam, it can be overwhelming because you're noticing a lot of words, you don't remember what they mean, and you're panicking. But trust me, a lot of the times, the doctors want to make the question look hard, but it's actually really straightforward. So let's go to it one by one. So are they prodrugs that must be converted to triphosphates to be active? Yes, like we said, they need phosphorylation to be active because we want them to be nucleotides, not nucleotides, right? So this is true. Do they replace the 3-hydroxyl group with an azeto group? We don't know what azeto means, right? We didn't take it. I didn't see it in the lecture, so now you're panicking. However, we do know about NRTIs is that they lack a 3-hydroxyl group. That's how they terminate the DNA strand, right? So we know that they do replace the hydroxyl group with something else, but we don't know if this is the azeto. So this is 50-50. We're not sure. Are they pure and pyrimidine derivatives? Yes. We said they're nucleoside analogs, right? Or yeah. So do they bind to the allosteric site of reverse transcriptase, cause blah, blah? We don't know what this means. We don't remember more, right? So just think about it. NRTIs, do they bind to the enzyme itself? No. Okay, this is a very important distinction to make between NRTIs and NRTIs, which we will get to in a bit. Okay, NRTIs, they don't bind to the enzyme, they don't do anything to the enzyme. All they do is compete with nucleotides on the strand, which leads to the termination. Okay, so they're working on the reverse transcriptase step, but they're not binding to the enzyme itself. Okay, so this is the one that's false. Now, what is the primary mechanism by which nucleoside reverse transcriptase inhibitors terminate DNA elongation? Like we said, it's because, I'll give you some time. Okay, they lack a 3-hydroxyl group. Now, next one, NRTIs. Now, these also are working on the same step. We're still in the reverse transcriptase step. However, they work differently. What they do is, unlike the NRTIs, which compete with the nucleotides for a spot, the NNRTIs are non-competitive. What do I mean by non-competitive? It means they don't resemble anything that's naturally found in the body in order to compete with it, okay? So what they do is they go and directly bind to the enzyme itself, leading to a change in the shape of the enzyme, conformational change, and it leads to the enzyme being inactive or ineffective, okay? So very easy to remember, non with non-competitive, and non for no need for phosphorylation because it's not a nucleotide analog. Okay, so this is the main things you need to know in case they come in questions. Non and no need. Very easy to remember. Non, no need, and N. Okay. Now, what are the two ones you need to remember? Efavirenz and etravirine. Now, how I remember it personally is the vir here is sandwiched in between the two ends of the word. So I like to remember it as it's sandwiched between the two ends. Okay, so NNRTI, it's the one that has vir in between the two ends of the word. Okay, the most important side effect for efavirenz is vivid dreams or CNS symptoms or manifestations. Okay, so EFA vivid, remember EFA vivid. Okay, so for vivid dreams, etravirine, it's just the second generation of the NNRTI. So this is the one that works against resistant strands. So resistant T, T. Okay, vivid, the V sounds like F, vivid, okay, F vivid, okay. So the one with the F is the vivid dreams, the one with the T is for the resistance strands, it's the second generation, okay. So this is how you can remember them. Now, I'll give you a second. It's very quick recall, okay? So here, just you need to differentiate. Now, when you get this name in the exam, you're trying to remember which one was the etravirine. Just remember the vir is sandwiched between the two ends of the word, so it's the NNRTI. And how does the NNRTI work? It binds to the enzyme itself, okay? It does not bind on the primer. It does not compete for anything, okay? So just having a clear understanding of the mechanism of action can really help you get the questions right, okay? Now, let's say we were not able to stop the reverse transcriptase phase, okay? And the DNA strand was able to be formed. What's the next step after the formation of the DNA strand that we can target in medication? It's the integrase. What the integrase does is that it integrates the formed DNA strand, the viral DNA, into the host DNA, okay? So this is the job of the integrase. We have drugs that target this enzyme, okay, which are integrase inhibitors. These are like one of the easiest ones. It's in the name. It's like they made the mnemonic for us. So they have Tegra for integrase. Okay, very easy to remember. What I need you to remember from this, the main side effect or adverse effect with these medications is that they increase creatinine kinase, okay? So remember this as integrase or integrase, okay? So CK, creatinine kinase, they increase creatinine kinase, okay? Now, I'll give you a second, it's just quick recall. Okay, very easy. Let's say again, we were not able to stop the integration phase, okay? We can target the final step of the process, which is the protease. Now, after the integrase integrates the viral DNA into the host DNA, it's going to start transcribing mRNA proteins because what's the thing that does the damage to the body or that makes us sick? It's the viral proteins that the virus produces, right? So it's going to produce proteins, but they're immature. Okay, what the protease does, it cleaves these viral proteins into mature final viral products or viral particles. Okay, so if we stop the protease, we'll have immature proteins and we will have less of the mature viral particles. Okay, so this is the last step, which is the protease. Now, what you need to remember is that it's reversible. What do we mean by reversible? Is that when it binds, it doesn't stay there the whole time. It can, like, after some time, it will detach. Okay, so it's reversible. It doesn't bind permanently, okay, to the protease. Now, the protease inhibitors, they end with navir. Now, be careful. There are a lot of medications that end with vir. Okay, the ones that end with navir are the protease inhibitors, and the doctor gave a nice mnemonic, which is navir tease a pro, as in never tease a pro. Okay, so this is an easy way to remember it. Now, quick run through the questions. Please feel free to pause. I'm just for the sake of time. Okay. Okay, very easy. It decreases the formation of final viral products. Now, this is a summary for you guys to pause and kind of like collect your thoughts, okay? Now, for the second part of the crash course, I really recommend that you guys, if you have not been pausing along the way of the video, that you pause now and just quickly review the antiretrovirals, okay, before you move on, because I don't want the information to get jumbled up because I am going a bit fast. Just, I don't want this crash course to be too long for you guys, okay? Okay, so let's continue. Now, chemotherapy. For the leukemias, we have 4 types of leukemias, ALL, AML, CLL, and CML. Okay, now this is a summary of basically the regimens that we use for each. Okay, let's start with the first one. Now, the ALL, okay, basically how we treat it is we alternate between course A, which is hypercvad, and course B, which is methotrexate and cytarabine. Okay, so we give a cycle of these medications, then a cycle of these, and a cycle of these, and a cycle of these. Okay, this is how we treat ALL. Now, the focus or like for your level, the doctors will not really test you on how exactly like the dosage or the regimens, or that's not how exactly they'll test you on. What the doctors really care in this stage of your education in 3rd year is that you know the mechanism of action of each drug and the adverse effects. Okay, this is the most important takeaway, and that you in general know which drugs are used for what. Okay, so don't go into too much detail. Don't panic over the details of the lectures. صراحة usually never asked about, so hopefully it stays that way. Okay, let's start. So CVAD, it stands for something. Okay, the C stands for cyclophosphamide. The V stands for vincristine. The A stands for adriamycin, but in lectures, in questions, in exams, you'll see it as doxorubicin. This is the term we usually use. However, in the mnemonic, it's referring to adriamycin. However, they're the same thing. Please keep that in mind, okay? The D here is for dexamethasone, which is a steroid. We're not really going to talk about it in this lecture. It's not that important, but just know that the D here is for dexamethasone, okay? Now, let's start. What's important here? Mechanism of action and adverse effects. So how do we memorize these? In any cancer drugs, there are usually 3 ways in which they work, okay? They either cross-link the DNA, or they work on the mitosis, or they work on topoisomerase. These are usually the 3 main, like, mechanisms of action. So write them down, okay? cross-linking C, M for mitosis, and T for topoisomerase. Let's say you forget this order, CMT. It's the order of the alphabet, like A, B, C, D, F, G, H, I, J, comes before M and M comes before T. So if you forget in the exam, just write down, for example, C and M and T, okay? So let's say you forgot, let's say you wrote T, C, M, it's okay, just order them in the order of the alphabet. It will end up being C, M, T, okay? Now, I always use this, and till now it makes me remember these drugs, okay? So the C in CVAD, the cyclophosphamide, crosslinks, okay? So match the C with the C. The V in vincristine works on mitosis, and the A, which is the adriamycin or doxorubicin, works on topoisomerase, okay? So this is a way to kind of clear out your thoughts. Now, let's go into detail for each one. The cyclophosphamide, how does it cause the cross-linking in guanine and 7? It's because it's an alkylating agent, okay? So please remember that it's a prodrug. It's converted to the phosphoramide mustard to be active. However, it's صراحة not that high yield, okay? But just keep that in mind. Now, cyclophosphamide, like we said, it cross-links the DNA. How does it do that? Because it's an alkylating agent. Okay, now, the byproduct of the cyclophosphamide is acrolein. Acrolein is very toxic to the bladder, so it leads to hemorrhagic cystitis. So if they get you a question, okay, this is a very high yield, definitely going to be asked about this, okay? Side effect, most adverse side effect of cyclophosphamide, hemorrhagic cystitis. What can we give with cyclophosphamide to minimize the risk of hemorrhagic cystitis? It's mesna, okay? Because mesna basically neutralizes the acrolein, which is what the toxic substance that causes hemorrhagic cystitis, okay? So if you get a question, what do we prescribe alongside cyclophosphamide? Okay, mesna, okay? Don't forget that. Now, for vincristine, like we said, the V is with the M, okay? So it works on the mitosis or the M phase, okay? How does it work on mitosis? By inhibiting the tubulin spindle formation, okay? So very easy to remember, because if you remember the M, you can remember everything with it, tamam? Now, how do we remember the side effects? So vincristine, Vinsa, okay? So Vinsa, she can't crawl, can't crab, her bone marrow can't take a nap, okay? So this is the best mnemonic that stays with me, honestly, to remember. So can't crawl refers to peripheral neuropathy, because peripheral neuropathy means it's affecting the arms and the legs, which are the limbs, okay? Because the neuropathy is not central. It's not in the brain or the cerebellum or the spine. It's not central, okay? So the patient will present with peripheral neuropathy. They will present with tingling and numbness and weakness in the limbs, okay? So can't crawl. When you crawl, you're using your limbs, right? Your legs and your arms. So that's a way to remember peripheral neuropathy, okay? They do not present with balance issues. Balance issues or ataxia is central neuropathy, okay? So can't crawl. For can't crawl is the paralytic ileus, okay? So their digestive system is like on pause or on hold. It's paralyzed, okay? So they can't really go to the bathroom. So just remember that. Her bone marrow can't take a nap. This is really important because this is one of the very few drugs in chemotherapy that do not cause myelosuppression, okay? And doctors love to ask about unique features of their drugs, okay? They don't like to ask about things that you see in all drugs. So that's why I'm focusing on these. So her bone marrow can't take a nap. It means it needs to keep working. It's not suppressed, okay? So this is how you can remember vincristine. Now, for adriamycin or doxorubicin, a way to remember this, like we said, it's for topoisomerase, right? The A is with the T, okay? So it inhibits topoisomerase, okay? And it inhibits intercalation of the DNA. So easy to remember, okay? Now, doxorubicin, ruby, if you see, there's the word ruby in doxorubicin, which is a red gem or a red stone. This is a ruby, okay? So this should help you remember that red urine, okay? It can cause red urine. Another thing, this picture reminds me of a heart, okay? It's red, like it's shaped almost like a real heart. So remember that the most distinctive adverse effect of doxorubicin is cardiotoxicity. Okay, so really, really important. If they're in the question, they're telling you cardiomyopathy or congestive heart failure or ECG changes, anything related to heart, then this is the culprit usually. Okay, so what do we prescribe with doxorubicin to minimize cardiotoxicity? Okay, it's dexrazoxane. Very easy to remember because doxorubicin, dexrazoxane, like they look similar. Okay, so remember these go hand in hand. Now, one thing to remember, why is this drug the only one that leads to cardiotoxicity when all of them are inhibiting like DNA formation and multiplication and why is this one specifically causing the cardiotoxicity? Because it leads to free radical formations. And free radicals, if you remember from mole, from pathology even, oxidative stress on free radicals is one of the most damaging things for the heart. It's like what smoking causes, okay? Oxidative stress, free radicals, and so on, okay? So cardiotoxicity, remember free radicals, doxorubicin, red, remember this picture, okay? Now, what's one more thing? Yeah. What if they get you a question where they're describing a patient who's gonna be started on doxorubicin, and they're asking you which of the following should be used to continuously monitor the patient before and during doxorubicin? Answer would be echo. Okay. Very easy to remember because remember doxorubicin, the most important adverse effect is cardiotoxicity. So we need to keep making sure that the heart is safe. Okay. Now, okay, so we're done with the hyper-CVAD, which is course A. In course B, we said it's methotrexate and cytarabine, okay? Now, methotrexate is really easy. We've seen it in 100 other blocks. It comes literally every block, methotrexate, okay? DHFR inhibitor, okay? Very easy to remember. Now, if there's one thing you can remember from methotrexate is hepatotoxicity and pulmonary fibrosis. So if they get you a question and they're telling you the same thing, the patient is going to be started on methotrexate, which of the following should be continuously monitored? The answer would be LFTs, okay? Because hepatotoxicity is one of the most prominent adverse effects for methotrexate, okay? Please remember that. I unfortunately do not have a mnemonic for this. However, it seems to be like it's the only drug that has an H. So I guess that can remind you of hepatotoxicity, okay? Pulmonary fibrosis, this can come up on questions too, actually, okay? Even though it's really rare, but the fact that it's so special and unique adverse effect, doctors love to ask about this sometimes as well, okay? So they can get you a patient that presents with pulmonary fibrosis or imaging suggests pulmonary fibrosis, then they were probably on methotrexate, okay? Now, last one is the cytarabine. Cytarabine, everything is rhymes with the first letter, okay? So it works on the S phase of DNA polymerase, okay? Um, it inhibits DNA polymerase, specifically works on the S phase, okay? The adverse effect, everything starts with a C. Cerebellar toxicity, corneal toxicity, conjunctivitis, okay? If you notice the reason I'm skipping myelosuppression, it's because it's in all the drugs. I don't think they'll ask you about this. If they were to ask you about myelosuppression, they would ask you about which one doesn't cause it, which is vincristine, okay? Now, okay, so if you see here, cerebellar toxicity presents with ataxia. So if they're presenting a patient for you who's losing balance, okay, then they're referring to cerebellar toxicity or central neuropathy, okay? So in that case, you would choose cytarabine. However, if the patient is presenting with tingling, numbness, and stuff on the peripheries, like on the arms, on the legs, okay, that would be the peripheral neuropathy, which is for vincristine, okay? Corneal toxicity, everything starts with a C, and it works on the S phase, which rhymes with the C, okay? No, okay. One really, or two, no, one, yeah, one really, really important point that you need to take away from this lecture, okay, is that if you have a cancer where the patient tests positive for the BCR-ABL gene mutation, or in other words, they have the translocation 922, or in other words, the Philadelphia chromosomes involved, because all of these three terms mean the same thing. Okay? If this is the underlying genetic cause of the cancer, then the treatment changes. It's always a tyrosine kinase inhibitor, okay, which is any drug that ends in tinib, okay? And if you guys remember from the other lectures, most chronic myeloid leukemias or CMLs are BCR-ABL positive, okay? So that's why the treatment for CMLs is always tyrosine kinase inhibitors. Always, okay? Because in CML, there's always this mutation, okay? However, there is a small subgroup of ALLs, okay, that have this mutation as well. So in those little groups of ALLs where they're positive for this mutation, the treatment would be the TKIs, not all of these drugs that we discussed. Okay, so let's apply this quickly to questions. So feel free to pause. Okay, like we said, if anywhere in the question you see that the defect is in the BCR-ABL, or there's translocation 922, or the defect is in the Philadelphia chromosome, okay, then it's always the treatment is the TNIPs, okay, which are the tyrosine kinase receptors. So the way they can ask you about this, there are many ways, but this is one of them. Okay, I'll give you a second. Again, if you see that they're treated with ALL, which means hyper-CVAD, okay, and then hyper-CVAD and methotrexate cytarabine, okay, this is the regimen for ALL. And they tell you there's a cardiotoxic side effect, immediately doxorubicin, remember, okay? Again, I'll give you a second, okay? Very high yield, just recall, remember, okay? Like we said, when you see CVAD for ALL, it's either cross-linking, mitosis, topoisomerase. And the order of these three letters is the order of the alphabet, okay? Then just match C with the C, V with the M, and A with the T, okay? So mitosis, so vincristine. Like we said, free radicals and oxidative stress, same thing. Very high yield, same thing, okay? So does it work on mitosis? No, that's vincristine. Does it work on topoisomerase? No, that's adriamycin or doxorubicin. The cross-linking that it works on as an alkylating agent is on the DNA, okay, obviously. Also basic recall. If they ask you which of the following acts as an anthracyclic, then it's doxorubicin, okay? Now, going on to the second one. So we're done with the ALLs, very easy to remember. There is one thing I forgot to mention. Yeah, in refractory or relapsing ALL, we also add this to the regimen, which are CD19 inhibitors. This isn't the most high yield, but just in case, they're Kymriah and Tecartus, okay? Okay, moving on to AML, the regimen for it is AD or ADE. Now, the A here stands for aracytarabine, okay? However, just be careful, the A here in ALL, it stands for the adriamycin, which is the doxorubicin, okay? They don't stand for the same thing, which is very inconvenient. However, it's fine, okay? And the D here is for dexamethasone. However, the D here is for the daunorubicin, okay? Now, let's start. So, like we said, the regimen is AD, which is aracytarabine. We already talked about it in the ALL, so I'm not going to add it again. And the D is for the daunorubicin, okay? Now, it's also an anthracyclic like the doxorubicin. They work the same, the side effects are the same, red urine, cardiotoxicity, it's the same. And the way it works is the same, okay? However, the chemical makeup of daunorubicin is more effective on AML than doxorubicin. That's why we use this one for AML. However, we use the doxorubicin for ALL. Okay? However, like they're the same class of drugs. Okay? Now, remember how we said it's either AD or ADE? We add this E when it's relapse or refractory AML, which is the etoposide. Okay? Now, um, the most important thing to take from etoposide is that it can lead to secondary leukemia. Okay? I can't stress this enough. Please remember this. It can lead to secondary leukemia. Okay? So, yeah, please remember this. Okay, now we're done with the acute leukemias. Moving on to the chronic ones, they're really easy. So the CLL, there are two main classes of drugs that we use. They start with a B. Okay, so BTKIs and BCL2 inhibitors. Let's start. So remember how we said tyrosine kinase inhibitors? They always end with TNIPs. We'll just add the BRU because brutin TK inhibitors, they end with brutinib. So all the drugs that end in brutinib are BTKIs. The second class of drugs that we use for CLL is BCL2 inhibitors, like venetoclax. Okay, now um, one thing to remember about BCL2 inhibitors that's really important is that there's an increased risk of tumor lysis syndrome. Now, I did not include it in the lecture. I think it's discussed somewhere else, but I'm going to briefly go through it because it's really important. Okay. How do I remember this? It's BCL2 leads to cell lysis. Okay, so the cell will lyse. Okay, so cell lysis, tumor lysis syndrome. Okay, what's tumor lysis syndrome? Usually, when we're using anti-cancer medications, we're killing the cancer cells, right? So sometimes that happens too quickly where many cells are going to break down. Many tumor cells will start breaking down. This will release a lot of the contents of the cells into the circulation. Okay, so when that happens, you'll have tumor lysis syndrome, which is hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, and metabolic acidosis. Now, they can ask you a question on these. Okay, so just remember that everything is hyper except calcemia. Calcium is low. Okay, so everything is high except calcium. Okay, now really important to know how to treat this because this is a medical emergency. Most important thing is hydration, IV hydration, and then allopurinol. Okay, so just go back to the lecture and review this. I don't think this is I think this was discussed somewhere else more detailed, I'm sure. But if it's not, I'm sorry, guys, just go back to the lecture just in case, familiarize yourself. But this is basically what you need to take away from it. It's how it happens. It's because the cancer cells or the tumor cells they're all lysing, they're all bursting. Okay, so a lot of this content, this toxic content inside those tumor cells is released into the bloodstream. How does it present? Everything is high except for calcium and acidosis. How do you manage the patient? IV hydration is number one and allopurinol. Okay, so this is what you keep in mind. Now, last one, really easy. Like we said, CML is usually positive for the mutation in BCR-ABL or the translocation 922 or Philadelphia. They all mean the same thing. That's why very easy to remember that the treatment for CML is always tyrosine kinase inhibitors. Okay, so the doctor did include the different types of tyrosine kinase inhibitors. Now, personally speaking, I don't think this is that important. However, I did memorize it like when I had the exam, like briefly, very briefly, because what if one question comes, you can easily answer it, okay? So, okay, very easy way to remember the main idea. So, imatinib, I'm number one, okay? I'm number one, I'm always number one. So, uh, stupid, but whatever works. Okay, so this one is the first line. Why? Because it has the most like tolerable side effects. Okay, edema, muscle cramps. Okay, it's it's first line, doesn't cost much. Perfect. This is the one that we usually use. Okay, now the B here, I remember it as its bathroom, makes you go to the bathroom. Okay, so the Nilo, low, like for long, okay, law, L-O, so it leads to QT prolongation. That should remind you cardiovascular. It has cardiovascular effects, okay? Ponatinib is very severe, it has very severe side effects, okay? Um, the way I remember this is not, like saying no, like nah, like this is really bad. Why would you use it? So NA, just remember nah. So really bad side effects, severe thrombosis, myocardial infarction, stroke, really bad. So this one is only reserved for when you have a T315 mutation. Okay, so this is honestly enough to remember. This one is the odd one out. So if you don't see any of the other things you memorized, then it's probably this one. Okay, so I don't think, there's no way you need to know more than this. I don't think so. So this is just a summary. Like we said, for ALL, we have the hyper-CVAD and then as the first course, and then course B is methotrexate cytarabine. Remember that if you see any of these in the question, the treatment would be the TNIBs or the tyrosine kinase inhibitors. And remember that if it's refractory ALL or relapsing ALL, we add CD19 inhibitors. Okay, for AML, by the way, for these, I think the doctor would, if she were to ask about it, the option would be CD19 inhibitor, not the names. However, just keep them in mind, okay? For AML, really easy, AD or ADE, okay? If it's relapsing, we add the etoposide, okay? And remember, what does etoposide cause? Secondary AML or secondary leukemia, okay? Really important. Please remember this. Etoposide can lead to secondary leukemia. The A here, what does it stand for? Aracytarabine. And the D here for daunorubicin. Okay. For CLL, we use BTKIs or BCL2 inhibitors. CL for cell lysis, so it can lead to tumor lysis syndrome. And then for CML, we use the TKIs. Why? Because they're mostly all positive for this. Okay. Now, just a quick run through the questions. Okay. I'm going to give you a second to pause because I'll quickly go to the answer. Okay. Again, okay, keywords. Another keyword, same thing. Okay. Super easy. So again, I really recommend you guys pause at this point if you haven't been pausing throughout the lecture. Connect your thoughts, okay? Go through the slides or take a moment, take a breather, and then come back, okay? I think it's the best way to retain information because it is scientifically proven that when you do a big chunk of studying in one go, that your brain retains the first part and the last part. Okay, the middle kind of gets jumbled up. Okay, so if you keep taking breaks, then each time you start is technically the first part, so you'll retain more. Okay, just just for you guys' sake. Okay, anyways, if you want to keep watching, keep watching. So let's start. So this lecture and shouldn't take long. Inshallah, this one and the iron are one of the easier ones. So let's start. Okay, we're almost done. Big chunk of the work is done. So, uh, okay, malaria. So let me take you through the cycle very briefly. I'm not going to go through details. However, if you did take the details in micro, please know it. Okay, they love asking about these things. No, I'm just going to go into enough detail for the farm. Okay, now what happens with the malaria? We have the Anopheles, the female Anopheles mosquito. Okay, it's infected with the plasmodium. Okay, because it took it from another human. Okay, it's going to come to a healthy human and it's going to inject the sporozoites into the blood. Now, the sporozoites are going to travel to the liver of the human, okay? And inside the hepatocytes, it's gonna start like reproducing, okay, or replicating into merozoites, okay? Lots and lots and lots of merozoites. One sac of merozoites is called a schizont. So this whole thing is called a schizont, okay? Okay, I'm not gonna write the whole thing, just okay. Now, when it starts replicating inside this hepatocyte, the hepatocyte, like okay, the hepatocyte, it can only hold in so much, right? So at some point, it's going to rupture. Once it ruptures, it's going to release these merozoites into the blood. And what they're going to do, they're going to run to the RBC, the erythrocytes. And they're going to do the same thing. They're going to go inside and then they're going to become so many, so many, so many, so many, so many, so many. okay, just like they did in the hepatocyte. And the RBC can also hold in so much until it's had enough, okay? So it's gonna happen, it's gonna rupture, okay? So this is called the erythrocytic phase. This is called the tissue phase or the liver phase, okay? So where the merozoites are in the liver. Once it ruptures from the RBC, these merozoites are going to be free roaming around in the blood. This is when the person is very sick and symptomatic. Okay, they're going to present with fever, with chills, with, all the very sick signs. Okay, now we have drugs that target each stage. Okay, but just to continue. Now, after multiple cycles of infecting an RBC and rupturing, and infecting an RBC and rupturing, and doing whatever they want with the in the body and going crazy, okay? After multiple cycles, we're gonna go, I'm not gonna go into the details, okay? But in the end, you're gonna get gametocytes, okay? These gametocytes are what are taken up by the mosquito, okay? So my art is really, this is the mosquito. Okay, so the mosquito, when it comes and draws the blood of an infected person, what it's taking with it is the gametocytes. Okay, so that's why the gametocytes are what are called they're what cause the transmission to the mosquitoes. Okay, so now let's go through the drugs now that we know the cycle. So one thing to keep in mind before I start the drugs, okay, is the Vivax, okay, Plasmodium vivax and Plasmodium ovale are the only two that have a dormant liver phase. What do we mean by dormant liver phase? It means, okay, same thing for all this cycle that I drew for you guys is the same thing for all the Plasmodium. The only difference is that in Vivax and ovale, you'll have many of these, okay, wait, sorry, okay, in the liver, dormant, they're quiet. What do we mean? The patient is going to come very sick, right? Which means they're in the erythrocytic phase, okay? So you're going to give them drugs, okay, to target the parasites. They're going to feel better, the fever is going to go down, everything is fine, they're going to go home. Then after a while, they're going to relapse. Why do these patients relapse? It's because they have dormant liver forms, which means, do you see these clusters in the hepatocytes? They'll have many of them just like latent in the liver. And each period of time, a few are gonna rupture, not one. A few are gonna rupture and the cycle is gonna continue. Okay, so the relapsing sickness of a person is because there are dormant liver forms, and the dormant liver forms is only in Vivax and Ovale. So if you get a question, now I'll go through the questions like really well just to make sure that idea is clear. Okay, now, how do we memorize all of this? There's a mnemonic for each one. Now, for the dormant liver forms, or the liver forms in general, TP is sleepy. So tafenoquine and primaquine, remember, TP is sleepy, so they work on the dormant liver forms, which should remind you that they work on the liver in general, okay, the ones that are in the liver. So TP is sleepy. For the erythrocytic parasites, QCAM, as in cue the cameras, okay? Whatever works, desperate, okay? So Q is for quinine, C for chloroquine, A for artemisinin, and M for mefloquine. These are all the drugs that work on the erythrocytic phase, okay? However, we mainly use chloroquine and artemisinin, okay? This is the therapy or regimen that we usually use for the patients. Now, for the gametocides, remember, gametocides are what cause the transmission from human to mosquito. So these are really the ones that are spreading the infection from person to mosquito, then mosquito to person, person to mosquito, okay? So if we can kill this phase, okay, we are minimizing the transmission to the mosquitoes, okay? Which means we are protecting more people, right? So the mnemonic for this is prevent transmission and quit. Okay, so primaquine, tafenoquine, artemisinin, and quinine. Okay, so these are the four things, the four drugs that are used for the gametocides. Okay, so this is basically what you need to know. Okay, I just want to focus on one thing. Okay, um, Okay, if you get a question, okay, where they're describing to you a patient uh, who is sick and they're asking you, how do we, and they tell you that the patient has, like, we know it's Vivax, okay, Plasmodium Vivax. What medication do we give to like as a radical cure? When they say radical cure, it means we want to clean out the underlying cause, which means we want to clean out the dormant forms, right? Because these are the ones that keep making the patient relapse and relapse and relapse and relapse. So by radical cure, radical means the root cause of the problem. So when they're asking for this and it's Plasmodium vivax, then the answer is always Primaquine. This one also works, but usually I don't know why in examinations doctors like to ask about this one. But just remember TP is sleepy. Another way they can ask you this is they'll tell you, for example, how do we prevent recurrent relapses? Same thing, same idea. Okay, so basically that's it. Okay, now let's go into detail with the blood schizanticides. Now, okay, these are not the most important. However, it's good to know, and I will be focusing on the most important things. Now, mechanism of action is important because you might be asked about it. So basically, the plasmodium or the parasite, okay, uh, it's in the blood, okay? So it's gonna digest hemoglobin. When it digests hemoglobin, it's gonna give you heme. And heme, it's very toxic for the parasite. So the parasite protects itself from the heme by polymerizing it into hemozoin. So this drug, the wait, okay. This drug, what it does is it prevents the production of hemozoin. So now the heme is toxic to the parasite and it kills it. Okay. Now, what's really important is that if they get you a question, for example, someone is traveling to an endemic area. Okay. This area is known to have like high counts of malaria and everything, and he wants to protect himself from the malaria. What do you give that patient? Chloroquine. Remember C for chemoprophylaxis. This is the main drug we use for prophylaxis, okay? Mafloquine also works, but this is the main one, okay? So this is also an important point. It's safe for pregnancy, okay? This is also important to remember. S for C, I mean, whatever works, okay? Now, if they get you a picture in the OSCE where it's like a blonde or bleached strand of hair, and they ask you what medication can cause this, chloroquine. Remember this as like, it's the word that says Clorox. I mean, yeah, in the name of the drug, you can see almost Clorox, right? And we know chlor, like the one we use in the pool and cleaning detergent, okay? Clorox or chlor, it's a bleaching agent, right? So that's a way to remember. Now, for quinine, what's super important to keep in mind is the side effects, okay? Now, how to remember this? Remember a queen that's standing on like stage or in ceremony in front of all her people. Okay, this queen is gonna get very nervous. She's gonna get blushed. She's gonna get blurred vision, tinnitus, nausea. Her heart's gonna like stop. Like very very slowed down. So all of these side effects, okay, should remind you of quinine because they like asking about this. For prolonged QT, just think that she gets like a heart pause, from how nervous she is, okay? Synchronism is another word that describes the group of symptoms like blurred vision, tinnitus, nausea, blah, blah, okay? Now, and remember it's given IV. So if they get you a question, okay, and they're telling you any of these side effects, please remember the queen, okay? The queen that's standing on stage. Now, artemisinin, just remember that it works by the endoperoxide, it forms an endoperoxide bridge, which releases oxygen-free radicals that kills the parasite. And mefloquine, what's important, just remember neuropsychiatric toxicity, okay? So this is the main idea. Now, I'm going to give you just a second, pause. Okay, very straightforward. Remember the queen gets nervous, okay? Okay, now we're done with the blood schizanticides. Now moving on to the tissue schizanticides, or the ones we said target the liver or the dormant liver forms. Like we said, PT is sleepy. Okay. Now the main one the doctors like is the primaquine. So this is the only one I'm going to talk about. Like we said, it works on the dormant forms of Vivax and Avali because these are the only ones that have dormant forms. However, like we said in the mnemonic, prevent transmission and quit. They can also work as gametocidal and falciparum, okay? This is very easy to remember because we said prevent, transmission, and quit. These are the four drugs that are gametocidal. They work on the gametes because the gametes are the ones that cause the transmission, okay? Now, what's really important is that the primakine, okay, can lead to hemolysis in patients that are G6PD deficient. So if you get a question that we are starting the patient on primakine, okay, what is a test we need to order before starting the patient on primakine? G6PD deficiency. We need to check for G6PD deficiency. Remember the P with the P, okay? So okay, which of the following drugs prevents relapse, okay, of the Vivax malaria? Like we said, relapse is because of the dormant forms, right? So PT is sleepy, okay? Next, which of the following drugs causes G6PD mediated hemolysis? P for primakine, okay. Which drugs would you give patients with latent P. ovale and P. vivax? Again, latent means sleepy, means dormant. PT is sleepy, so, okay. Radical cure, and he has P. vivax. Radical cure. Radical cure means we are curing the root issue of the symptoms, okay? So root issue means we need to add the uh, primakine. Why? Because it kills the dormant forms, okay? This is a really important concept. Now, this isn't that important, okay? I don't think you'll need to know this, okay? However, just in general, what you do need to know is that chloroquine and artemisinin combination therapy are the mainstay of treatment for malaria, and they're given for 3 days each, okay? And if you can see here what we said, if the patient has Vivax and Ovali, we want to prevent relapse. We want to clean out the dormant forms in the liver, right? So we have to add primakine for 14 days. That's a really long time. So like, remember that, okay? So that's it. Very easy. So chloroquine and artemisinin. And then if it's Vivax or Ovali, we add primakine, okay? Now, if the patient presents with severe malaria, so in the scenario, you'll see really low blood pressure, lots of hemolysis going on, their liver is enlarged, they're not doing well. The patient is really unstable, okay? First line is IV artesunate. If this isn't in the options, you go with IV quinine. If that's not in the options, you go with IV quinidine, okay? So main thing to remember is it's IV, okay? Always, always in medicine, if a patient is coming to you and they're not doing well, they're very unstable, it doesn't make sense to give them a pill, right? Like by logic, right? If they're in the ER, they're not doing well, they're like very unstable, IV, because we need quick effect, quick response, okay? So I'm gonna go quickly, so just feel free to pause. So if you can see here, these are all the severe symptoms. So IV, okay, artesunate. Same concept. If you don't see artesunate or quinine, go with quinine. However, I do think that artemisinin is the answer in the past papers. However, I'm pretty sure it's not the answer, but very appealable question. If you guys like, if you've discussed this with the doctor already and they told you it's A, then go with A. I personally think very highly that it's D, because we do still use quinidine. However, very appealable question. Okay. Okay, again, same concept. Very severe, okay? If it wasn't severe, if it was just normal, uncomplicated, just normal malaria, there's nothing about severity, then the answer would be A, okay? Gametosite load, this is what causes transmission. So remember, prevent transmission and quit. Okay, so again, I recommend you guys pause. I'm gonna move on. So this one is the easiest part of the whole pharmacology. So let's start. Now, what are hematinics? Okay, hematinics are substances required for formation of blood. What do we need to form blood? We need erythropoietin from the kidneys, we need iron, and we need B12 and folic acid. So these are the things that we are looking at. Another way to classify them is based on the underlying deficiency or the underlying cause of the anemia. First cause is iron deficiency, so we give iron. Second cause is megaloblastic, so we give B12 and folate. Third reason could be because of chronic disease or kidney disease. in which we give erythropoietin. Okay, so these are the three things that you need to remember. Let's start with the iron. Now, iron can be given as oral or IV. Okay, now the like anything in pharma, the IV is not anything. Okay, there are some exceptions, of course, but in general, like as a rule of thumb, if there's an oral and IV version of the same thing, the IV is usually for the severe form. Okay, so it really depends on the clinical scenario that you have. If the patient is very unstable, low hemoglobin, blood pressure is really low, then you go with the IV. Okay, now oral is what we prescribe in our clinic. Like we saw in their labs that they have anemia or iron deficiency. Okay, we prescribe, iron. However, if they're unstable, IV. Okay. Now, the oral are salts. Okay, salts are the ones that end in ate. So ferrous sulfate, ferrous gluconate, ferrous fumarate. So the ate means it's a salt. Okay, so that can help you remember that ate is salt and we eat salt, so oral. Okay, so these are the oral forms. And salt starts with S, so it's the ferrous form. What do we mean by ferrous? Ferrous, S for second. Okay, this might be too many mnemonics for you guys, but this is how I study, so I'm hoping that someone can benefit from this like I did, okay? So I just like to connect things together. So ferrous means second, okay? It's the 2 plus, okay? Now, I'll get into why we give ferrous and not ferric in a minute. Now, what's the difference between ferrous sulfate, ferrous gluconate, and ferrous fumarate? It's just the percentage of iron in each one, okay? So the order is FSG, feels so great, okay? So this one has the highest percentage of iron, then sulfate, then gluconate. It's 33%, sulfate is 20%, gluconate is 12%. We prescribe based, like the main one we use is the sulfate. However, maybe someone would take the sulfate and they wouldn't be able to tolerate the side effects, so we go to a lower dose. Or maybe someone has very minor iron deficiency, so we go with the lower one. Okay. Now, why do we give ferrous and not ferric? Okay. Because even like in the food, in the meat, in vegetables, the iron naturally exists as ferric. Okay. However, the reason we give supplements as ferrous, so it's because, subhanAllah, our intestines are like made like this. Why? Because as you know, the main site of iron absorption is the duodenum, right? What comes right before the duodenum? The stomach. And the stomach is very acidic. So when the iron that we eat goes into the stomach, it reacts with the acid. Okay? So the ferric, which is the 3 plus, okay, it reacts with acid, okay, in general. Not vitamin C, like naturally in our body, there's acid, right? The HCl in the stomach. When it reacts with acid, it becomes reduced to ferrous, the ferrous form. Okay, so the intestine already knows that it's going to be expecting iron in the ferrous form. So the transporters and the channels in the duodenum can only work on the ferrous. Okay, so because it knows that the iron is going to go through the acid and it's going to be reduced. Okay, so because we're giving it orally, it's going to go through so it means it's going to go through the GI. We need to maximize the absorption. So we give it in the ferrous form. It's the best one. Okay. Now, what increases absorption? Acid. Okay. Because naturally in the stomach there is acid. So we want to even enhance this absorption process even more. So we give usually the oral tablets, we give them with vitamin C. Why? Because vitamin C is an ascorbic acid. It's acidic, right? Ascorbic acid is the name of vitamin C. The way I remember it sometimes, ferric 3 needs vitamin C. Okay? So I hope this is all clear. Maybe take a second to pause and gather your thoughts. Okay? So logically, if acid improves absorption, that means antacids decrease absorption of iron, right? That's why if a patient is already on antacids, like for example, they have gastric reflux, so they're taking antacids, or for any other reason, we always need to advise the patient to take their iron either 2 hours before their medication or the antacid, or 4 hours after they take their medication. Okay, so this is a really important point. And antacids are anything that's alkaline, right? Opposite of acid is alkaline. Alkaline substances are usually hydroxides. They end in OH. Okay, so just this is basic chemistry, like magnesium hydroxides. Hydroxides in general are alkaline or basic. Okay, now side effects, GI, anything GI, cramping, nausea, diarrhea, anything GI is a side effect of iron. However, the most important two to know are constipation and black stool. Okay? Constipation is really important to remember. It's the most common one, but it's also really important because it's the most common reason why patients do not adhere to their oral supplements or they're not compliant with their iron medication because they cannot bear with the constipation. Okay, so a lot of the people I even witnessed it myself in the clinics, they would come and they wouldn't be like compliant with their medication or the supplement, and they'll say because it up like the constipation is too much, I can't. So this is important to remember. And the reason that you get black stool is because naturally the bacteria in your gut produces sulfides. Okay, so the iron reacts with those sulfides to produce iron sulfide. Okay, FeS. If you remember from chemistry, this is a black compound. Okay, so that's why. Okay, so I hope everything is clear here. Now for the IV, the main one we use is iron dextran or ferric carboxymaltose. Now, if you notice here, why is the IV version ferric, which is the 3 plus? Because in IV, we're bypassing the GI system as a whole. Okay, it's not going to go through the GI. It's not going to be absorbed by the intestine. We don't need it to be ferrous. Okay, so we give the IV as ferric also because the transporters in the blood, the transferrin, they transport the ferric in the blood. They don't work on ferrous. Okay, ferrous is mainly as salt, so we eat it oral. It's mainly for the duodenum absorption, okay? However, everywhere else in the body, like the ferritin stores, transportation in the blood, everywhere else, it works on ferric, okay? So we give it in ferric because we're bypassing the GI, we don't need the ferrous, okay? But what's really important in IV is that we need to carefully monitor for toxicity because we can easily overload the body, okay? And the side effects are the side effects of any other IV medication, nothing special, okay? So I'm going to quickly go through, so feel free to pause. Okay, so if you can see here, rapid heart rate, okay? The blood pressure is 85 or 59, that's super low. Hemoglobin is 7, that's super low, okay? So this is severe what? Yeah, severe iron deficiency, okay? So that's why we go with the IV. تمام? Even they tell you in the question, severe, this is severe anemia, okay? Now, okay, this patient is very stable. Okay, he arrives for his checkup. Okay, he's complaining of fatigue. His skin is a bit pale. Hemoglobin is 8, which is low. Okay, he's diagnosed with iron deficiency anemia. He is stable. There's nothing here that suggests that the patient is spiraling or not doing well or he's stable, okay? He's just coming in for a checkup and he's complaining of some symptoms, okay? So we start him on oral. The only one that's oral here is A, okay? Be careful. They can bring you ferric fumarate, okay? Please be careful because as we said, if it's oral, it has to be ferrous, okay? S as in salt, we eat salt, so, okay. So, okay, which of the following has the highest percentage of elemental iron? Like we said, the mnemonic is FSG, feels so great, okay? So fumarate is not here. So the second one is sulfate. Again, be careful if the doctor brings ferric, please don't choose that. Okay, very straightforward. Again, most common constipation, okay? Okay, this question was removed. I think this question was removed from a previous. I'm not sure why though. Very straightforward, okay? However, I think it might be confusing with the options, okay? But just keep it in mind. Okay, now, nothing I can really do much here, okay? Please just read it. Like, it's very straightforward, honestly. Um, we give it, just know when it's given. Megaloblastic anemia, obviously. We give folic acid and B12. Also, if they describe in the scenario pernicious anemia, okay? then this is the treatment. Okay. Now, what I need you to keep in mind though is which ones are oral and which ones are IV, and just go like this is never asked about. However, like read it just for completion's sake. Like feel free to pause and just you know I'm sure you guys are watching this really close before the exam. So if you read it now, you'll remember it because like short-term memory. Okay, now erythropoietin, like we said, we give it for anemia of chronic disease, okay, or kidney disease. So there's exogenous erythropoietin, where it's like basically not the one your body's producing, obviously, or you can give an erythropoietin receptor activator, which is MR serum. It comes as an injection. Now, what you really need to know from this, okay, high yield, is that you need to make sure you're not increasing the hemoglobin by more than 1 gram per deciliter over 2 weeks. So each 2 weeks, you should only expect the hemoglobin to go up by one. If it's going up more than that, it's too quick or it's too much, okay? Because erythropoietin, what it does is it stimulates the production of red blood cells. And if you produce too many of them, if you think about it, your blood will be very thick. Okay, so very thick blood, it means really life-threatening cardiovascular event. It can clog the arteries, it can lead to thromboembolism, it can lead to infarctions. So we don't want that, okay? So every 2 weeks should go up by one and should not exceed beyond 12. Okay, this is the golden number, 12. And it's easy to remember because we said can't increase more than 1/2 weeks, every 2 weeks, 1, 2. 1, 2. Okay. Now, hydroxyurea is what we use for sickle cell disease. Okay. Now, this is technically the last part. So, what I want to stress on this is that hydroxyurea is not a treatment or it's not a cure. Okay. It's not gonna cure the disease. It's not gonna change any progression of the disease. All it's gonna do is it's gonna relieve the sickle cell crisis, or it's gonna reduce the or prevent the sickle cell crisis. So what happens in sickle cell disease, like you know from your other lectures, the sickle cells are gonna cluster up and polymerize, okay, because they can become in an insoluble state, okay? They're gonna cluster up and polymerize, and this will deposit in your microcirculation. It's gonna clog your circulation. So it's gonna cause ischemic pain. And guys, when I tell you I've seen patients, okay, at least 3 or 4, okay, that have come to the ER where they're crying and screaming on the floor from the pain that they're getting with the sickle cell crisis. Okay, so it's really severe. So this drug is life-changing. Don't think because it's not curing the disease, so oh, not that important. No, like we can't live without this drug. It's doing wonders. Okay, so what it does is really important to know how it works. What it does is it increases fetal hemoglobin. This is the main takeaway. Okay, so by increasing fetal hemoglobin, the way it works, it has a solubilizing effect on the sickled hemoglobin. Okay, so because it has that effect, it decreases the polymerization of the sickled cells. Okay, so it decreases or prevents the sickle cell crisis. Okay, so this is a really important medication. Okay, just know it increases fetal hemoglobin and how the fetal hemoglobin basically has a large solubilizing effect. So less polymerization, so less sickle crisis. Okay. So as we said, it does not alter the progression. All it does is it reduces the frequency and severity of the crisis. Okay. Now, myelosuppression is a no-brainer, okay? How because it works on the DNA, the underlying mechanism. However, remember that it causes hyperpigmentation. How do you remember that? It has urea, okay? Urea is what gives the color in urine, right? So just remember that this causes hyperpigmentation. Now, very quickly, okay? Really important to remember this, okay? Erythropoietin makes the blood really thick. Okay, it's not to treat, it's not to cure, it's not to slow down progression. Okay, it's not anything. It's just frequency and severity of the crisis. Okay, now for the chelators, I'm very sorry. There's nothing I can do for you guys. However, Just read it, okay? Take a moment now. Don't postpone this to later. I know you're gonna keep saying, I'll do this later, I'll do this later. Just pause now and give it a read, because honestly, it's very straightforward, okay? And here, all you need to know is when we use each one. Okay, so for lead, it's the EDTA. For arsenic, gold, mercury, it's dimercarpol. For Wilson's, it's penicillamine. And know the side effects in red and in bold. Okay, I tried my best to look for mnemonics for this or make them myself, but I couldn't. Okay, so please, guys, just give this a good read and know which iron chelating agents is oral and IV. Okay, okay, okay. So furoxamine is oral. Okay, so anything else would be the IV. So here the IV, no, sorry. Deferoxamine is the IV. I'm so sorry. It's the parenteral one. And deferocero is oral or the deferocerox. Okay. So I think this is a typo, no? Is there an X here? Same thing. Okay. X or without X. This one is the oral one. Okay. Please remember this. Okay. This is really high yield. Okay, we're done for today. So if you guys have any questions, please let me know. My number is in the beginning of the lecture. Okay, and please feel free to give me your feedback, else I can make these lectures better and better over time. Okay, so good luck, everyone, and thank you for attending, and best of luck on your exams, inshallah.